Yeah. Good morning, everyone. My name is Ezaldeen Abu Shareah. I'm a core surgical trainee here too, currently working in Derriford Hospital. I have done this audit last year when I was in TNO placement. And this is the second cycle. We have done the first cycle the year before. This audit is auditing the British Orthopedic Association standards for trauma and orthopedic guidelines for management of distal radius fracture. So the aim of this audit is to ensure radiographs are being requested appropriately for robust indications and to ensure compliance with the guidelines, and thus clinical resources are used effectively. So basically, POST states that repeat radiographs of the wrist between 1 and 2 weeks after injury or manipulation, where it's thought that the fracture pattern is unstable and when the subsequent displacement will lead to surgical intervention. And that means you need to repeat radiographs, you need to repeat X-rays for patient with distal radius fracture if the fracture is unstable, and also if there's any displacement, you are planning to do surgical intervention. Otherwise, no need to repeat the X-rays. Methodology, we used our systems bags to look at the X-rays and then classified them into stable and unstable fractures. We looked at the X-rays in July, over 3 weeks, from the 1st of July to 21st, 2023. ICM was used to see the patients who attended the fracture clinic. Trauma secretary folders to access the clinical letters and to see the impression of the surgeons who have seen the patients in fracture clinic and their impression about the fracture, stable, unstable, or if there's any changes happened after the initial trauma that might trigger requesting new X-rays. Then fractures were classified into either stable and or unstable based on the initial X-rays obtained in ED. So the first presentation X-rays out of cast. We used published criteria. This is the criteria we used to differentiate stable and unstable fractures. So mainly we use the volar or dorsal comminution, dorsal angulation more than 5 degrees or more than 20 degrees of the contralateral distal radius, radial shortening more than 5 millimeter, and displaced intra-articular fractures more than 2 millimeters. Also presence of other injuries like ulnar fractures. So this is mainly the criteria that we used to classify the fractures into stable and unstable. So we presented the first cycle of this audit in our orthopedic audit meeting in May 2023. And we put like algorithm or poster in our fracture clinic saying that is the fracture stable or unstable. So if that means if undisplaced or minimally displaced fracture, or you are not planning to do intervention, there is no need for X-rays and should proceed with conservative management. And the second cycle, so we found that we've got 24 patients who got stable fractures. None of them were manipulated, and none of them the position change on repeated X-rays. Surgical fixation, none of them had surgical fixation. 6 of them had at least 1 X-rays, and 2 of them had 2 or more X-rays. Some patients had 3 or even 4 X-rays, although the fracture was stable from the first instant. We've got also unstable fractures, 32 patients. Position change in 15 patients, like after the initial presentation. 12 patients ended up having an operation. We had 9 patients who had at least 1 X-rays, and 23 patients had 2 or more X-rays. So the total study was 56 patients who had were seen in fracture clinic in March 2023, and we said 12 patients ended up having fixation. So if you see here, radiographs, like we said, we classify the patients into the fractures into stable and unstable. You can see from the stable group, we have 8 patients who had unjustified repeat radiographs and 16 patients who had no repeat radiographs. In the unstable group, we had 3 patients proceeded directly to surgery without repeating X-rays. 27, they've got justified radiographs because, like we said, they are unstable, so you can't repeat the X-rays for them. And 2 patients, they were having severe comorbidities, and the plan was they had repeated radiographs, but they ended up with conservative management because they are not fit for operation. So this is 2 cycles together. So we can see there's like improvement in the second cycle. So we had 18 patients in the first cycle had unjustified repeated radiographs, compared to 8 patients only in the second cycle. And also in the unstable group, we had 3 patients who had unjustified because of their comorbidities, or in the second cycle, we had only 2 patients. So the results of second cycle, in total over 3 weeks period, at least 15 repeat radiographs were taken of fracture which we considered stable, or the fracture or unstable fracture with significant comorbidities, all not leading to surgical intervention. And these are some examples of patients with stable distal radius fracture. As you can see, there's minimal displacement. It's extra-articular fracture, no angulation, no shortening. Still, this patient had one X-ray. Like after 1 week, he had another X-ray, which changed nothing. There was no change in the plan. Still, the patient was treated conservatively, and according to the letters, fracture clinic letters, there was nothing change after. There was like no another force or trauma that triggered repeating radiographs. So this X-ray was not indicated. This also another X-ray. This patient also had another X-ray after 1 week. Again, as you can see, there is stable fractures, and this X-ray also not indicated. As you can see here, this is an intra-articular. We think this fracture is unstable. However, this patient is 87-year-old with a past medical history of lung cancer, active lung cancer, stroke, AF, COPD, polymyalgia on steroids, and peripheral arterial disease. And the patient had repeated X-rays, but then he was treated conservatively because of the underlying comorbidities. And the question now, why we have repeated X-rays if we are planning not to intervene because of the underlying conditions. This is another patient who is 90-year-old patient who got unstable fracture in the first presentation, but still severe frailty, squamous cell carcinoma, high blood pressure, heart failure, and also ended up with conservative management because of the underlying comorbidities. So in conclusion, we have 15 instances of radiographs which could have been avoided in the second cycle compared to 30 radiographs in the first cycle. So we increased the compliance from 53 to 67 against post guidelines, which is good. And this could also, we said, like avoiding these radiographs reduce radiation exposure, so increase patient safety, reduce cost to patients in hospital, and allow space for other patients. Thank you very much.